wish to talk to you this evening about the emotional side to living with a chronic condition such as diabetes, with a focus on type 1. Currently, this area is recognised but under-supported in diabetes care in Australia. It is my hope that this can become more normalised in diabetes care, just as you would get your eyes checked or your feet checked. Because we know that living with the condition is more than just testing your blood sugar levels and managing your lifestyle. It can impact you emotionally, mentally, and socially. So I'm going to be covering lots tonight. I hope to get through it in time. So I'll cover what a psychologist is and how it's involved in diabetes care. We'll look at some psychological problems that can arise in diabetes management and how we can address those problems, as well as looking at carer stress as well. So what is a clinical psychologist? So we're a registered health professional with a minimum of 6 years of university training and supervised experience. We provide assessment and diagnosis of mental health issues and psychological problems to people across the lifespan. We use evidence-based techniques and strategies to address psychological problems, and we tailor these to the individual. We try to take a biopsychosocial approach to health, where we consider the individual's biological background. So in this case, it would include your diabetes management. We also look at psychological factors or individual factors. So this could be your history, your coping skills, your personality, behaviours that you engage in, and your belief systems. We also take into account the social context in which someone lives. So this can include the level of social support, their family background, cultural traditions, socio-economic background and education levels. So what has psychology got to do with diabetes management? As we know, diabetes relies heavily on self-management behaviours to keep it in balance. Engaging in behaviours isn't always as simple as just following instructions. So our health professionals might instruct us to have a go at changing certain aspects of our diabetes management, but it's not always just straightforward to follow that. Because behaviours are influenced by many factors. It can be influenced by the mood that you're experiencing at the time, your beliefs about the value of engaging in those behaviours, your personal preferences, the physical state that you're in at the time, your social environment that you have to do that behaviour in, past experiences and many more factors. Engaging in behaviours isn't always simple, let alone changing those behaviours. We're creatures of habit by nature, and so then to shift to change to new behaviours can present quite a challenge for us. It requires a lot more cognitive effort, and that can be tough for us. So a psychologist can help you to understand what factors help you to engage in new behaviours, but also things that are getting in the way. Psychologists also help out with mental health issues, and I'll speak more about that tonight, and so that can help with your diabetes management if that's looked at. Tonight I'll be discussing a lot of challenges that can be associated with living with diabetes, but I want you to remember that most people can and do live well with the condition. I think we've got Theresa May back here as well, but there's some other more well-known faces who live with diabetes. So we've got Marsha Hines, the singer, getting her blood sugars tested at the pharmacy, as well as Nathan Bassett, who's a former football player with type 1 diabetes as well. However, some people with diabetes will need some support, and that's okay. And that's why psychology is involved in diabetes care. So I like this quote from Jen Nash. She's got a book called Diabetes and Wellbeing, which you'll see later on. And she captures diabetes like this. Life with diabetes can be hard work. Diabetes has been likened to a job, not just any job, but one in which you have to work 24 hours a day, 7 days a week, 365 days a year, with no holiday, no praise and no pay. I don't know about you, but I wouldn't stay working in a role like that for very long. But the individual with diabetes doesn't have the option of walking out or giving up. They have to keep working day in and day out for the rest of their life. Diabetes is unlike other chronic health conditions, which may wax and wane and flare. It really needs to be attended to daily, and that's what makes its management sometimes so challenging. This is another quote from a woman with type 1 diabetes, and she says it's a scary thing, always hearing about how diabetes can cause serious complications. Health professionals just throw these things out there to scare you into looking after yourself better. But instead it just makes you want to go more into denial about it. This head in the sand approach is what often brings people to come and see me, where their diabetes has become so overwhelming that they want to pretend that it doesn't exist anymore. That, of course, creates some consequences for them, hence why they need to get extra support. So that leads me to talk about diabetes distress. So this isn't a mental health disorder, but it is a condition associated with having diabetes. It refers to the emotional burden of living with and having to manage diabetes and its relentlessness, that day in and day out management. But also that prospect of developing long-term complications. If left untreated, it can start to impact on your daily life, including work or school, but also your diabetes management. Diabetes distress exists on a continuum from mild frustration and annoyance on the one hand, all the way up to severe distress at the other end. Diabetes distress can differ between diabetes types as well, with those with type 1 diabetes finding that they become more distressed by the insulin treatment and management and having to manage their hypo and hyperglycemia levels. Whereas for those with type 2 diabetes, the distress seems to be associated more with social consequences of having the condition, as well as managing food intake and weight. Diabetes distress may present when there are other life stresses going on, and this is what I commonly see in my practice, where diabetes sort of takes a bit of a back seat for a while, and it's as though people will get to it later once they've sorted other things out. But as we know, and we'll see, that can start to have an impact on your diabetes, but then also those life areas when it's not attended to. So diabetes distress may present on and off throughout your life with diabetes, so it's important to become aware of how you're travelling and to nip these things in the bud. If left untreated, it can develop into a mental health condition like depression or anxiety disorders, which I'll talk about a bit later. So what does diabetes distress look like? It's quite different for different people. But often some characteristics can include feeling overwhelmed by the demands of living with the condition, feeling like you're failing with your diabetes management, worry about the future with diabetes, feeling frustrated that you can't predict or control it from one day to the next, or feeling guilty if it gets off track. Some people experience very real or perceived discrimination or stigmatisation. This can occur also in the workplace, and I worked with a lady who was refused breaks at work and wasn't able to have snacks on her, and that presented real challenges for working at that environment. This perceived surveillance by others as well can get quite distressing for some people, particularly in social situations, people making comments about the foods you're about to eat. There can be a lot of financial costs associated with diabetes management, and this can be even harder for those on lower incomes. Disengaging from self-care tasks is one way that you might pick up that you've got diabetes distress. Also unhealthy or uncontrolled eating, which I'll talk about more. Risk-taking behaviours, so not taking your insulin, letting your blood sugars run high, or overuse of alcohol or other substances. And finally, not attending appointments. So this book here, called Diabetes Burnout, is an American resource by William Polonsky and is a useful self-help resource. People with type 1 diabetes also have additional stress with technology use. We saw earlier in Anthony's presentation some of the benefits that can come from all these changes with new technologies. However, there are studies that show it's not always beneficial for everyone and that needs to really be tailored to the individual and presented at a time that's more appropriate than others. In particular, this study by Tannenbaum found that women in particular didn't like devices on their body and became quite distressed by that in terms of their body image. For some people, the costs of technology was distressing, as was time and effort required to still use the devices. Inaccuracies, they're not perfect systems and they still require a lot of work. Not liking alarms going off all the time can be distressing as well. And some of these factors have led people to stop using devices like your CGM or your pumps. And this has been shown to be the case particularly among young people. And what it showed was that they were often presented these new technologies at times of transition where they were having to manage other life stresses at the same time, whether it was work or study or relationships. So I think the use of technology is the way forward in diabetes management, but it does need to be considered how the individual will respond to that. So diabetes distress impacts more people with type 1 diabetes than type 2. But interestingly, a recent study called the MILES study in 2016 found that those with type 1 diabetes had greater physical well-being, however had more diabetes distress than those with type 2. The sample was a bit younger in the type 1 sample, suggesting that they perhaps hadn't developed some of the health complications. But it was also suggestive that in order to keep your diabetes within that optimum range, it came at an emotional cost. In youth, a MILES youth study found that diabetes distress was more common in girls than boys, and in particular girls worried about their weight. Whereas for boys, they were more concerned that family and friends didn't understand how difficult living with the condition was. As well, they felt that other people acted like the diabetes police, telling them off and telling them what to do. There's also parental distress that comes with diabetes, and in particular, parents seem to worry about the child developing complications, also feeling like they are the diabetes police, and becoming upset when their child's management is off track. So there are some vulnerable times for developing diabetes distress, and these include really times of change or transition. So soon after diagnosis presents a time, this is when the dust starts to settle, appointments start to spread out, and you have to now live with the reality of the condition. Any changes to routine or treatments, medications, technology, again, that can provide an added burden to managing the condition. The development of complications down the track can present a time of real grief and loss for people, where they might have to adjust to new ways of doing things, might have to accept help from others, may need help in the home or mobility supports or vision supports, etc. Attending lots of medical appointments as well can get tiring, and it may not just be for diabetes, it might be for other conditions as well. And as I mentioned earlier, just other life stresses can mean that diabetes gets put on the back burner. And this has been shown to be the case particularly for young adults, where they have a higher rate of dropout going between the paediatric and the adult diabetes services. So that's often a time of transition in terms of education and relationships as well. So what do we know about stress? So stress is a really useful mechanism that our body responds with all of these physical symptoms, which I'll go through. And it's really useful that the body does this automatically without us having to tell it to. So we call this the sympathetic nervous system activation, or the fight, flight or freeze response. So essentially the brain will perceive a threat in the environment, and it will tell the adrenal glands to release stress hormones like adrenaline and cortisol. This then has the effect of making changes in our body, including increasing our breathing rate and our heart rate. It will raise your blood sugar levels to give you energy to respond to the situation. It'll slow down your digestion because you don't need to digest lunch at that time. Increase sweating, things like that. So it can be quite uncomfortable, these physical sensations, but it is your body trying to help you out. However, this stress response isn't designed for long-term use, and so having diabetes for some people can be a chronic stressor, and it may not be quite at the extreme physical symptoms, but it can be sort of in the background constantly, having to be on alert and thinking about your diabetes. So in the longer term, being under chronic stress can impact your fatigue levels and your sleep, keep your blood sugars elevated as well as your blood pressure, impact your immune system and put pressure on your cardiovascular system. In diabetes, a fight response might look like getting really angry or upset with having diabetes, becoming preoccupied with how easy other people have it that don't have diabetes, a sense of unfairness around having the condition. A flight response is more of like an avoidant response. So this is where you might avoid going to appointments, reduce your testing, not bother carb counting, not eat well or exercise as might be recommended. So this is that head in the sand approach we saw earlier. A freeze response is where you might become so overwhelmed that you become immobilised with your diabetes care, and it becomes hard to make decisions, and you might leave that decision making to other people, usually a family member, which then sort of puts the strain on them. You might experience a combination of these responses when you're under diabetes distress. So I'll come to the management of that in a moment. Moving on now to mental health conditions. So depression is a serious mental health issue which requires treatment and diagnosis by a health professional. We all experience low mood at times, that's part of the human condition. But what we're talking about here is when it becomes problematic is when it's persistent and it's starting to impact on your daily functioning. So it's characterised by a 2-week period or more of a change in previous functioning and feeling depressed in your mood or a loss of interest or pleasure in your usual activities, but also about 4 or more of the following symptoms. So changes in weight unintentionally, changes to your sleeping patterns, either over or under sleeping or broken sleep, feeling agitated or slowed down, changes to your energy levels, difficulty concentrating and making decisions, feeling worthless or guilty, or recurrent thoughts of death or suicide. So in people with diabetes, major depressive disorder can impact diabetes outcomes both in the short and the long term. So it's really important that treatment is seen to sooner rather than later. So in type 1 diabetes, depression is a little bit less common than for those in type 2. It's not quite understood the mechanisms why, but it has been proposed to be due to different biological factors, different behavioural and social factors as well. Having a family history of depression will put you at higher risk for developing depression as well. In young people, the rates may be slightly higher, with the Youth Miles study showing that up to 25%, so 1 in 4 young people experience depressive symptoms, and that was higher for girls. The good news is, however, that it is treatable. We've got lots of evidence-based approaches that work, and it's important, like I was saying, to accept help for that and to put your hand up and say, you know, I need a bit of assistance. And that's seen as a real sign of courage that you're willing to take charge of your emotional health, which can also help others who you might be living with as well. So anxiety is another area that's associated with diabetes, either directly or indirectly. So this is characterised by persistent or excessive worry. We all worry at times, but it's really the degree and the persistence of it that it becomes problematic. So it's a sense of feeling really uneasy or worried, irritable or panicked, a belief that you can't cope, feeling quite restless, fidgety, unable to concentrate, starting to avoid your usual activities. And it does have some physical symptoms associated, similar to those stress symptoms, so increased heart rate, sweating, trembling, dizziness. There are lots of different types of anxiety disorders, and experiencing them can impact your diabetes management. But specifically to diabetes, what we see in our clinic is a fear of hypoglycemia. So this is quite uncomfortable for a lot of people, and so naturally they want to avoid that. But sometimes they overcompensate by leaving blood sugars running high, not wanting to go out just in case they have a hypo episode, or avoiding physical activity, etc. So again, that has potential ramifications in the long term and needs to be looked at. Some people also worry about developing long-term complications, and it either goes one of two ways. It's that head in the sand approach and avoiding doing what's needed, or becoming over-focused and really quite rigid in diabetes management, over-checking and becoming really stressed out by specifics and numbers to a T at the expense of other life areas. Needle phobia, or fear of needles, is something I commonly treat, as well as a fear of choking or a strong dislike of taking medications. So again, these can start to have an impact, and we've got some really great evidence-based approaches that can help in these areas. It's tricky though with anxiety, because sometimes the physical symptoms can mimic what a hypo episode can look like, with the tremors and the sweating and the palpitations. This is something that requires a bit of attention and training to work out what's happening. Just really briefly and initially, you could guess what your blood sugars you think might be, test it and start to see where your awareness is, and then start to make a note of what things were going on before those symptoms started, to start to see if there's any patterns, whether something stressful was going on immediately prior to those symptoms, or what your eating or exercise was like just prior. So we're looking at about a 1 in 6 prevalence of increased anxiety in type 1 diabetes. But again, for young people, that's a bit more prevalent, almost 1 in 4. Disordered eating is another area which I commonly see in my practice. So diabetes in itself requires you to be mindful of your food choices and your eating behaviour. So there is a certain vigilance that is required to manage the condition well. It becomes disordered though when it becomes a really stressful experience and impacts on your well-being. So things that I will see is being overly restrictive in your food intake, overeating and non-hungry eating. So that's eating in response to perhaps emotions or food just being around and not really taking into account whether or not you need it. Becoming really focused or over-focused on food and eating and your body image can be another sign as well. Feeling really guilty after eating or being really critical of what you should or shouldn't have eaten can become unhelpful, as are unhealthy weight management behaviours. So at the extreme end, people might use laxatives or excessive exercise or purging to manage their weight, but it's really quite uncommon to see that. So for those with diabetes, what we more commonly see is binge eating or binge eating disorder, which is a clinical condition, or changing your insulin doses to try to manage your weight, which can be very dangerous and lead to hospital admissions. So like I was saying, it can develop into more clinical problems, but that's quite rare. So conditions like anorexia nervosa and bulimia nervosa are much rarer. There is a sub-condition called diabulimia, which again is that changing your insulin to try to manage your weight. So the prevalence is around 2 in 5 for type 1 diabetes. In girls in particular, in youth girls, that is quite high, more so than for boys, and girls particularly stress about weight management while managing diabetes. Binge eating was more common in girls, and boys reported eating more when alone. So what do we do about these conditions which can come up in diabetes care? So a psychologist will try to do a really thorough assessment, and we've got some really useful tools that we use. And then we use some evidence-based strategies tailored to the individual to manage their distress. The assessment of psychological problems in diabetes is really the responsibility of any health professional involved in your diabetes care. They should at the very least be screening for emotional difficulties and then referring on to appropriate clinicians. So we follow this NDSS handbook, the Diabetes and Emotional Health Handbook, which is a really great resource that helps to guide our practice. So as I was saying, there's lots of assessment tools that we use, and some of these are quite specific for teens and parents of teens and type 1, looking at lots of different areas of diabetes and emotional health. So in terms of treatment, cognitive behaviour therapy has been around for a very long time, more recently being applied to the area of diabetes care. So it's also known as CBT. It's based on the idea that we need to develop realistic and balanced beliefs about situations, but it's not about thinking positively, which is a common misconception. Thinking positively about a really negative situation can be quite invalidating of your experiences. So we're looking at lots of different components. So if a situation comes up, diabetes related or otherwise, a psychologist is looking at what sort of thoughts are going through your mind at the time in response to that situation. What are the mood or feelings coming up in response to that situation? What are you doing or not doing in response, and how is your body responding? And we'll look at changing various components to enact change in how you're feeling and seeing the situation. So one of the target area is looking at unhelpful thoughts. It's quite common for people to come to me and say things like, my blood sugars are bad this week, my day is ruined now that I've had a hypo. Others are always harassing me about my diabetes. No one understands what it's like living with this condition. So these are very black and white statements or catastrophising statements. And so that can lead to lowered mood and motivation to care for your diabetes. So we use lots of different strategies, but one of them in particular is to look at really identifying how true these thoughts are, and are they absolutely 100% true all the time. So have your blood sugars been 100% bad all week? What is bad? Is it out of range? Is it going low? And sort of looking at, well, maybe perhaps if we looked at your diary, you'd see that sometimes it's out of range, but sometimes they were in range as well. So we don't want to put these sort of blanket descriptions on your levels either. Another question might be, what would be a more helpful way of looking at the situation? Saying that your day is ruined now that you've had a hypo, we might be able to think of it a bit more helpfully. So maybe your day started off a bit tricky, but are there some things that you can do to keep it a bit more balanced going forward, even if you are feeling slightly unwell? Another question is, what would I tell a friend in this situation? Often we're a lot more harsh towards ourselves than we would other people. And so this can be a good way to see if we're actually appraising the situation well or not. Finally, how likely is it that the worst could happen, and how would you manage it? So if you had a fear of hypos, putting in some contingency plans in place, and should that happen, how will you then manage? So starting to really empower you to think about the situations differently and not catastrophise them. So if we use an example, the situation might be seeing a high blood sugar reading, and the thoughts might be, nothing I do seems to keep it lower. What's the point in looking after myself? Which is that all or nothing thinking. This might lead you to then feel quite helpless and defeated and frustrated, and you might experience some muscle tension. Behaviours in response to this way of thinking and feeling might be to then avoid testing, like what's the point? You might drop some of your activities, you might become abrupt with family members, and you might eat unhealthy foods because, again, what's the point in looking after myself? So you can see this way of thinking then has that flow-on effect to perhaps some more ineffective behaviours. An alternative could be to start to reframe that way of thinking. So if we see a high blood sugar level, we might instead think, you know what, I'm trying my best to manage what is a tricky condition. This is a piece of data, it's useful information, so I can start to think back and look at what's contributing to these levels, and recognising that there are some things that you can do to lower it. So you might then still feel frustrated, but you might also feel curious and hopeful. You might be a little bit calmer in your body, and then your behaviours might be more effective. You might start to reflect back on recent experiences which might have contributed to the high blood sugar levels. You might be a bit gentler and kinder to yourself that day, and you might do something to help bring those blood sugar levels down. If we're targeting behaviours, there's lots and lots of strategies that we use as psychologists. One of them in particular is to set SMART goals. So usually when people come to see me and their blood sugars are out of balance, or they're feeling really distressed by the day-to-day management, they see that they need to overhaul their whole life, and there's lots of different areas they might need to shift. But what we do is try to really narrow it down and break it down to something a bit more tangible, a bit more simple, and start to change things one at a time. So we would set a goal that's quite specific, quite measurable, so you can see your progress over time, but also that's really achievable for them. So the example here is pairing your Lantus with brushing your teeth at night to create a healthy habit. And that might be all that we do for that week, just to sort of establish a healthier routine. Then once they've established that goal and got that worked on, we might set another SMART goal, and that starts to build their confidence in being able to re-engage with their diabetes care and do what's needed to manage. Another area of looking at behaviours is to problem solve stress that's going on. So this could be related to diabetes, but it could also be in other life areas as well. By looking at what is within your control, what are some possible solutions and getting started. Like I said, that head in the sand approach, that avoidant approach, often doesn't work for us in the long run. So furthermore, if we're looking at our physical sensations, we can target these areas in a number of different ways. Relaxation exercises are a really good one, and there's lots of different types that you can do here. Box breathing is a really easy one to remember. So the idea with it is that you visualise or see a box somewhere in the room and you follow that with your breath. So you would breathe in for 4 seconds, hold for 4, breathe out for 4, and then hold for 4 again. And so we can practice that now if you like. So I'll give you a moment. I want you to just settle in and try to breathe in for 4 seconds. Hold for 4. Breathe out for 4. Hold for 4. And repeat. If I got you to do that for 1 or 2 minutes, some of you would start to get a bit sleepy. It works really quickly to regulate that stress response that I spoke about earlier. It gives you a focal point to focus on your breath rather than any sort of mental chatter that might be going on. It allows your muscles to start to relax, and it really starts to slow down your breathing rate and heart rate. Progressive muscle relaxation is another technique where you work through and tense muscles from your head all the way down to your toes and relax them. That's another useful one. Engaging in physical activity is a great way to release some of those stress hormones as well. So the evidence for CBT, there's some out there, but less so in the area of type 1 diabetes. A more recent study with adolescents showed that it improved HbA1c and mood compared to just general counselling. So it can be applied to this cohort. If we move on now to acceptance and commitment therapy, or ACT, so this is a newer therapy that's recently been applied to diabetes care. So this involves acknowledging that the human condition includes pain, suffering and uncomfortable experiences, but that avoiding these experiences is detrimental in the long term. So it's about developing some strategies to learn to live with that discomfort and still do what's needed to live a well life, even with diabetes in it. So you might ask yourself, what do I want my life to be about, even with diabetes in it? And are the choices I'm making getting me closer to what I want for my health or further away? So it's an emerging area of diabetes research, with some studies showing some quite promising results. Another area is self-compassion, and this is based on the idea that being harsh and critical towards yourself as a way of motivating yourself often doesn't work. So if we tap into our innate soothing system and offer ourselves kindness and support during difficult times, this helps to reduce our stress response. So it's made up of 3 components: common humanity, recognising that we're all trying to deal with this tricky condition and that we're all human and make bad choices or are imperfect at times. Trying to be kinder towards ourselves and just becoming aware of our emotional health. There's lots of correlational evidence to show that those with higher self-compassion have better diabetes outcomes, but we're awaiting more randomised controlled trials for intervention studies. Engaging in self-care is really important for everyone, not just in diabetes management. So looking after diet and physical activity, getting enough sleep, maintaining social supports or improving them, and doing activities which give us a sense of purpose and meaning is really important. So how can you support someone experiencing diabetes distress? It's not about nagging and scaring people into change. That doesn't work. So it's about really coming from a compassionate stance and really validating the difficulties that can come up and recognising that it's okay to have negative emotions about diabetes. Recognising that diabetes is just one part of the person and engaging with them in other areas, focusing on what they are doing well, even if they can make some changes, and balancing that need to provide help with them building their own self-confidence in their management. Looking at carer stress, it's important to look after the carer. If we use the metaphor of an oxygen mask, if you've ever been on an aeroplane before, when the masks come down, the instructions are for you to put one on yourself before helping others. And the same for carers. You're of no use to your family member with diabetes if you're not looking after yourself as well. Ensuring that the person with diabetes is taking responsibility but also keeping involved as well, and making sure that you connect with your loved one in areas other than just diabetes management. Peer support is really helpful as well, and there's some more information on the Diabetes SA website. And finally, in order to see a psychologist about diabetes care, so there are 4 psychologists employed with intermediate care services where I work. You would need a GP referral to attend, and we do service the southern area. But more information can be found on our website under Diabetes Services for Silent on the SA Health website. Alternatively, you could see a psychologist through a GP mental health care plan, which enables you to get Medicare subsidised sessions. But the clinician may or may not have an awareness of diabetes management. Alternatively, you could pay out of pocket privately, and you can search for psychologists through the Australian Psychological Society website. Finally, there's more and more resources coming up in this area of diabetes management. There's NDSS fact sheets, which are excellent, and they might be out in the foyer. Sane Australia has a useful website and guide, and there are some various books that I've shown you this evening. I guess the take-home message tonight is really to see emotional health in diabetes care as being just as important as all the other areas, including your eye health and your feet health and your diet, etc. And to really check in with yourself every now and again to see, how am I travelling? Am I doing okay, or do I need a bit of extra support? And you may just start with your diabetes educator or your GP and just get that conversation going that you might need a bit of extra care. Thank you so much for listening tonight.